Hello everyone, a very good evening. After a long time I'm doing this video, sorry. Hereafter I'll post the video regularly. Just text in our telegram group the videos or the content that you need me to post in our YouTube channel. So first we'll discuss on definition in this topic, that is stridor in children. How do you approach a child with a stridor? Definition for stridor here is, so definition of your stridor. So stridor is nothing but a high pitched sound. So it is a high pitched sound that is produced by high pitched sound that is produced by your airflow turbulence. By your airflow turbulence through a partially obstructed airway. So this partially obstructed airway can be present either in your supraglottis or in your glottis, or it can be in your subglottis region also. So stridor is nothing but your high pitched sound that is produced by your airflow through a partially obstructed airway. Okay, so this is the definition of stridor. What is the principle behind this stridor? The principle behind this is your Bernoulli's principle. What does your Bernoulli principle tells? So when there is an increase in the velocity of the air, which will be directly proportional to decrease in the pressure. So when there is an increase in velocity, will be directly proportional or it will occur simultaneously with decrease in pressure. So when the velocity of the air increases through your narrowed airway. So I will draw here. This is your narrowed part of your airway, this one. So when a velocity of the air increases through this part, air increases through your narrowed airway, there will be a decrease in your linear pressure. So there will be decrease in the linear pressure on the airway valve. So there will be a decrease in the linear pressure on the airway valve. So thus resulting in airway collapse. This airway collapse is transmitted as a harsh sound that is called as stridor. So this airway collapse is transmitted as harsh sound that is called as stridor. Understood the concept behind your stridor? It is mainly due to your Bernoulli's principle. Yes. So how do you localize whether the pathology is in your supraglottis or in a glottis or subglottis or in your tracheal region? So for that we have a few findings. So when there is a stridor during the inspiration, so whenever there is an inspiratory stridor, then anatomical localization can be present in supraglottis. The pathology will be in your supraglottis. When there is a biphasic stridor, that is the stridor when it is present throughout your inspiration and expiration, it can be either, the pathology can be either in your glottis or in your subglottis. Next, if the stridor is present only in your expiratory, then the pathology can be present in your tracheal region. So this is a simpler way of identifying, by seeing a patient, a simpler way of identifying the or localizing the pathology where it can be present. Right? Next, the causes for your stridor. It can be either congenital or acquired. The causes will start from the nasal region. The congenital cause are in your nasal region that can lead either in a child is choanal atresia, while in your acquired it can be your nasal polyp. In nasopharynx region, congenital cause can be your pharyngomalacia, or it can be your mid-face hypoplasia, like in your syndromes like Crozon syndrome. So they can have a stridor because your mid-face hypoplasia. While in acquired condition, this can be due to, your stridor can be due to adenoid hypertrophy. Okay. Yes. Coming to your oral cavity, the congenital cause can be your micrognathalia or it can be your macroglossia. There are many congenital reasons, that is due to your syndromes. Midface defects can also lead to your stridor in child. That can be the causes in your congenital. I have mentioned only a few, that which one you can easily remember for your theory exam, or which you can easily write in your theory exam, because you will not find enough time to cover all the points what all you have read. So you just need to write an important points in your theory exam. Fine. Yes, in your acquired causes, it will be your tonsillar hypertrophy and retropharyngeal abscess. Okay. Yes. Well, going on to your larynx, the congenital cause can be your laryngomalacia and lingual thyroid. It can be your This laryngomalacia is the most common cause of stridor in a chronic setting. It will be your laryngomalacia. So this is the most common. Okay. Yes. While in acquired region or acquired cause, it is your epiglottitis. In glottis region, laryngeal web. In acquired condition within the glottis region will be your foreign body obstruction or can be your vocal cord palsy. In subglottic region, congenital cause will be your congenital subglottic stenosis. In acquired, it is your croup or angioedema, or it can be your post-intubation subglottic stenosis. It can be a post-intubation subglottic stenosis. So these are the causes related to your subglottic region. While in trachea, your congenital will be a tracheomalacia. While in acquired cause, it can be foreign body obstruction, or it can be your bronchial tracheitis, bacterial tracheitis. Right? So these are some of the causes of stridor in a child. So how are you going to evaluate which are the conditions you will be evaluating? So what are the other symptoms associated with the stridor will lead you to further investigation and management, we'll see here. So the red flags that when you find in a stridor, so is first one, onset at birth. So red flags in stridor, that's your associated symptoms with stridor that will lead on to a alarming condition which will require a urgent investigation and management. So one is onset at birth. Second, when the child is having facial dysmorphism. Third, when the child is having a poor weight gain. Fourth is your history of prior intubation. Fifth, when the child is hypophonia or aphonia. Sixth, when the child is having a recurrent apneic episode. So these are the red flags associated with the stridor. Suppose if the child is having atypical features or these red flags, they need an additional investigations. So what are the additional investigation that can be provided to this child? One is your chest x-ray. Chest x-ray, for example, in a child with a croup, you will be seeing a steeple sign. The steeple sign will indicate a obstruction or edema or obstruction of your subglottis region. Okay, that is in croup. Second one will be your bronchoscopy or your laryngoscopy. Okay. So this bronchoscopy is a gold standard investigation for confirmation of your anatomical pathology of your airway. So when you leave a bronchoscopy, you can find the pathology whether it is in a supraglottis, glottis or in a subglottis region. Okay. So this bronchoscopy will be your gold standard investigation. Right. Yes. Third one. Other conditions that require further investigation can be your echo. CECT chest, and next you can do another called as drug induced sleep endoscopy study. Drug induced sleep endoscopy. Fourth will be your polysomnography. So these are the other additional investigation which the child will require according to their red flag signs. Next, coming to management. This management will be vary from case to case. So management varies according to the cause. Okay. So in a group, what will be the treatment for this child? You will be giving adrenal nebulization, and you will be giving oral or nebulization with steroids. Okay. Next, for epiglottitis, antibiotic is the treatment of this. Next, for foreign body aspiration, it is bronchoscopic retrieval. So bronchoscopic retrieval will be your treatment for a child with foreign body aspiration. For retropharyngeal or a parapharyngeal abscess, you will give the child antibiotic with or without surgical drainage depending upon the condition of the child. Next, coming to the chronic setting, the causes will be your choanal atresia. For choanal atresia, the treatment of choice will be your transnasal surgery with stenting. For adenotonsillar hypertrophy, it is adenotonsillectomy. For laryngomalacia, it will be your because laryngomalacia, the child will go in for poor weight gain. So you have to treat the child with anti-reflux measures and supraglottoplasty. For subglottic stenosis, it is your balloon dilatation with laryngotracheal reconstruction. It is balloon dilatation with your laryngotracheal reconstruction. Right, this is for subglottic stenosis. For your tracheomalacia, the treatment will be your CPAP therapy with iotopexy. Okay, so these are the management of a child with stridor. So this is how you approach a child with a stridor. Okay, thank you so much for your patience listening. I'll post this PDF in our Telegram group. So our Telegram group is our PETS University Exam Discussion Group. PETS University Exam Discussion Group. This is our Telegram group. Okay, if any MBBS student are watching our video, please post your topic which you needed for your exams. Okay, let me try to post it in our videos, because this topic are mainly for the PG students, for MD, DNB and DCH students. Supposing if MBBS students want me to post video, just write the topics, I'll post the videos. Okay, thank you so much for your patience listening. Let's all learn pediatric together.